Welcome to the Scientific Sense podcast, where we explore emerging ideas from science, policy, economics, and technology. My name is Gill Eapen. We talk with world's leading academics and experts about their recent research or general areas of topical interest. Scientific Sense is an unstructured conversation with no agenda or preparation. We cover a wide variety of domains where new discoveries are made and new technologies are developed on a daily basis. We are most interested in how new ideas affect society and help educate the world how to pursue a rewarding and enjoyable life rooted in science, logic, and information. We seek knowledge without boundaries or constraints and provide unedited content of conversations with researchers and leaders who love what they do. A companion blog to this podcast can be found at scientificsense.com, and this podcast is available on over a dozen platforms and directly at scientificsense.net. If you have suggestions for topics, guests, and other ideas, please send them to info@scientificsense.com, and I can be reached at gill@eapen.info. My guest today is Professor Peter Muennig, who is a professor at Columbia University's Department of Health Policy and Management. He uses randomized controlled trials, RCTs, and other methods to study the social determinants of health from a health policy perspective. His work spans broad areas of non-medical health policy, linking RCTs with cost-effectiveness analyses to determine the best mix of social policies for optimizing population health. Welcome, Peter.
Thank you. Thank you for having me on your show, Gil.
Absolutely, yeah. So I want to start with one of your earlier papers entitled Considering Whether Medicaid is Worth the Cost, Revisiting the Oregon Health Study. So the Oregon Health Study was an experiment in which uninsured participants were randomized to either apply for Medicaid or stay with their current care, right?
Right.
And so what did you find by going back into it and looking at the data?
Well, so one piece of what we did was, in the original Oregon Medicaid study, there was a lot of controversy because they found that when people were randomly assigned to receive Medicaid, they were much more likely to be diagnosed with, high blood pressure, high cholesterol, high blood sugar, diabetes. But they were not found to have any impact associated with having a treatment for their disease. So in other words, despite these diagnoses, the blood sugar and the blood pressure and the blood cholesterol levels didn't really decline.
Yeah, so there was a concentration of hypertension, diabetes in the group that applied for Medicaid?
It was a little bit lower than average. It was lower than they expected. And that was part of the problem. And that's really where the crux of the problem with the study came in, is that, because they had a lower prevalence than the researchers expected, this statistical power, which is the number of people that you need to enroll in this study, was weak. If you're studying a very sick population and you're giving them medications, you would expect to see big effects. But if you're studying a population, that's pretty healthy, you don't see these big effects. So that was the big controversy, and the politicians jumped on it. They said, well, look, Medicaid isn't doing anything for anybody, so we should get rid of the program.
Right.
So what we tried to do is we tried to fix that problem by using a combined test on one of Columbia's supercomputers that would look at changes across all of these three measures. And what that effectively does is it increases the power of your test. It's kind of like adding participants to your study.
Mm-hmm.
And we found that even with this added power, there wasn't really that much of an impact on these three measures. But nevertheless,
Yeah.
just having health insurance had all of these other beneficial effects on your psychological well-being, and that alone paid for the health insurance.
Wow. Yeah, I mean that's so interesting. So if I for my own understanding, Peter, so when you look at the two groups, the ones in the Medicaid program and the ones who are not, there isn't enough statistical power to make any conclusions. Yeah, hypertension, cholesterol, and diabetes, these three conditions specifically, right?
Correct.
And so we can't really conclude anything, and politicians can spin it whatever way they want to make
Right.
the
As they're
decisions. But more importantly, if I understand this correctly, what you're saying is that just the idea that you have a safety net, you have insurance, improved improved welfare and improved general health of that population, and you can actually put a number to it, some kind of an economic benefit number.
Yeah, that's right. Yeah, depression is pretty prevalent in the U.S. population, and the problem is getting worse over time. And there's this hypothesis that one of the reasons why things are really going downhill in America is because the well-being of Americans are declining, and that well-being is declining in part because you know these traditional high-paying jobs with health insurance are no longer available. So
Yeah.
the standard of living is declining, and people are getting more depressed. And we're trying to fix it with policies like Medicaid and with policies like the earned income tax credit and things like this.
Mm.
And then the big question is, obviously these things are not going to replace union jobs at Ford that we lost, but do they help? And the answer seems to be yes.
Mm.
So what we're seeing is increases in well-being, and the other thing about the Oregon health insurance plan that's sort of interesting, the study that's sort of interesting, is that it really relieved people's anxiety. So
Mm.
there was a qualitative piece to the study as well, and
Yeah.
in the qualitative piece, all sorts of things came out. Like people were saying, it's funny, I broke an arm when I was uninsured, and I couldn't go to the emergency room. And I broke an arm again this time when I did have insurance and I could. And so my first bone wasn't set properly, and I was in a lot of pain. And this time
Mm.
I was treated properly. So
Mm.
that doesn't show up in the study, but it shows up in the person's well-being.
Right, right. Yeah, I mean, this is a such an important thing. One of my pet peeves is that both the providers and payers seem to treat mental health completely segmented from physical health. And, I think there is enough data that shows that, mental health and physical health are intimately connected.
Mm-hmm.
And unless you can treat the patient, both of these conditions together, you're never going to solve the problem. I mean, you can, you can push some part of your payment scheme to another payer, and you can play those games. But from the patient's perspective, the problem is never going to be solved, right? This is kind of a similar thing.
Yeah, absolutely. That's absolutely right. And as you said, it's really a two-way street. If you have a physical illness, especially one that you can't seek medical care for, that's going to be a big stressor in your life and is going to, lead to mental illness. Conversely, mental illness will also impact your physical health. And there's really, really interesting literature on this
Mm.
that shows that when you're depressed, when you're anxious, there is something called oxidative stress that happens when you have psychological stress.
Yeah.
And that increases the rate of aging in your body. So
Correct.
at the end of the day, you have a wide array of chronic disease coming out of mental illness.
Yeah, and oxidative stress in the brain is implicated for many of the degenerative diseases like Alzheimer's and those types of diseases too.
Yes, that's in fact, we're doing a study on that now. We're doing a randomized controlled trial that looks at unemployed public recipients of public housing, and the idea is to provide huge supplements for them if they find a job, as an
Mhm.
incentive for finding a job. But we're really in the first stage of the randomized trial. In the early stages, they found that people weren't really, even though they were offered this money, they weren't really able to go and get these jobs.
Mm.
And part of the reason was because the psychological stress damages physical structures in your brain that are responsible for executive function, which is sort of like looking forward, planning, executing those plans, those kinds of things.
Yeah.
So what we ended up doing in this randomized controlled trial was building in an executive function piece where we try to provide workarounds for the neurological damage that's been done by this stress so that people will have an easier time, getting the initiative to get a job and keeping that job and controlling emotions when they're on the job, those kinds of things.
Yeah. Yeah. So, the bottom line here is that, healthcare is not just about, having some sort of insurance for, physical issues that you might encounter, but it's really sort of treating the patient holistically, right? Holistically is not the right term, but really understanding where the patient is coming from and what the impacts could be from a stress perspective, from all the stress factors the patient might be encountering. And this has more relevance now, and we'll talk a bit about that in the context of COVID
Mhm.
as well. But before we get to it, Peter, I want to touch on a paper. It's the cost effectiveness analysis of the new rural cooperative medical scheme in China. And this new rural cooperative medical scheme, NCMS, is a universal healthcare coverage plan now covering over 98% of rural residents in China, first implemented in 2003. And rising costs in the face of modest gains in health and financial protections have raised questions about the cost effectiveness of the NCMS. So you did an analysis around this. What did you find?
Well, what we found is actually in flux as we're speaking. I mean,
Okay.
I'm not sure that the findings would still apply today because when the study was done, the NCMS had just been sort of rolled out.
Mm,
And the way that was rolled out is, China likes to do things, make their policies experimental. They even decided to convert over to capitalism experimentally, which is really cool, by
yeah.
creating, different zones that become capitalists. They're called special economic zones, and different zones that don't, and then compare those two. And that was sort of the impetus behind the new rural medical cooperative system because they wanted to see, well, if we did things slightly differently from one geographic area to the next, um, you know, can we sort of find a better model?
Mm,
Can we see what's working better than others? And so, in the interim time, the program has changed quite a bit.
mm.
So we were finding that some provinces weren't doing such a great job and others were.
Customize it to various regions. It works a lot better. Is that the idea?
Yeah, that's right. So when we first did the analysis, we found that it wasn't providing great value rolling out this program on average, but now it's been tweaked and they're finding value in the different, the different pieces of the health insurance scheme that are working. And so I think it is working better. The other sort of interesting thing that they've done is they've realized that you cannot just pay for half of somebody's medical bill. You really need to pay for at least 80% of their medical bill for it to work. And so that's what they're doing now. It's funny, this study was published only 2 years ago, but things move so quickly in China that that the conclusions of a paper can be nullified in just 2 years.
Oh, that's fascinating. Yeah. So,
Yeah.
I mean, it's a large country. What is the population of the rural population in China?
Well, now it is less than 50% of the 1.3 billion people in the country. So it's increasingly small.
Yeah.
And it's,
But still about 600 million or so.
yeah.
600 million, that's twice our population. And they effectively have universal health care for that 600 million.
Yes.
Yeah. So I don't know if any country has implemented anything like that at this scale, right? I know that India is nowhere near from a universal healthcare coverage perspective.
Right. Yeah. That's really a state by state thing. Kerala has done a great job, but other states not so much.
Right. So it's a good experiment to keep an eye on.
Yeah.
I want to jump into one of your recent papers, the promise of big data for precision population health management in the US. You say, the objectives were, as we enter the year 2020, health data in the United States is still in the process of being curated into a usable format. With coordinated data systems, it becomes possible to answer with relative certainty what preventative and medical interventions work in the real world and for whom they might work. And this has always been a problem for us, right? I mean, you think about EMR data, for example, there are something like 400 different EMR vendors. Many of those systems are designed by engineers without a good understanding of the workflow in healthcare.
Mm-hmm. Yep.
And they all use different terminology.
Yep.
And so yeah, talk a little bit about what you found and what your suggestions are.
Well, what we found is that that it's a disaster, and we've kind of known that for a long time. When Obama became president, he allocated, I believe, if I'm remembering correctly, $20 billion to standardizing electronic medical records so that they could talk to each other. And we haven't made a whole lot of great progress on that. We've made progress, but not the kind of progress that you would have expected to make over $20 billion in 12 years.
Yeah.
And the end result of this is that it's difficult to use these data for research purposes. It's difficult to use these data for healthcare purposes. So in other countries, almost any other wealthy country in the world, if you go to another doctor in another state, they can just pull up your medical records using, highly secure ID card, health card, or in some cases, even biometrically linked data to pull up your medical data securely. Here, irrespective of the security, it's in a completely different format, in a completely different silo, and a completely different system. So what happens is you go to doctor number 2, and then they have to just do all the same tests all over again. Repeat the MRI, repeat the,
Right.
And so that is very inefficient. And then from a medical standpoint, there is so much that we can learn from all of the variations in the way that medical care is delivered, and so much that we can learn in terms of where diseases, like rare diseases, the treatments that we've been trying on them, whether or not
Yeah.
they work. There's just a whole universe of things that can be learned. And if I could just sort of mention two counterfactual examples.
Sure.
In
Yeah.
there's a much more utopic world that people are living in. The best example is probably Estonia, and in Estonia, everybody has what's called a digital ID, and I know they're trying to do this in India and other places as well. And the idea behind a digital ID is that all of your data, not just your health data, but all of your data, which is all really useful for researchers, is put into one database. So in Estonia, if you want to open a business, you can do it in a second because they know what your credit history is, so you can get your loan. They know who your workers are because each of those people are linked to your ID.
Yeah.
And you have all the data on them. So if you're opening a restaurant, have they been certified in food handling? So it's instantaneous to open a business there. You can vote online. You can register for your DMV in under a minute, if you can imagine that, because they just have all the information that they need about you. Now, from a research standpoint, that is really useful because you have all this information over time. So you know the progression of disease, you know what treatment they've received, and if you sort of want to go back to the conversation we had earlier for 1 second,
Yeah.
you also know whether or not these treatments are working. So in the Oregon health insurance experiment, the politics aside, there was a valid research quandary that came up when they found that treating diabetes and treating hypercholesterolemia and treating blood pressure didn't really have an impact on your blood sugar or your blood pressure or your blood cholesterol. And one of the reasons is probably that people have a hard time taking these medicines consistently.
Yeah.
The medicines are probably a little bit less effective than they seem in these clinical trials.
Right.
And there is a really valid question that people are asking, which is, if your doctor diagnoses you with high blood pressure or high blood cholesterol, does taking the medication on average help you or harm you? Because
Yeah.
you need to treat 200 people to reduce to prevent one heart attack.
Right.
So going back to Estonia, you have that data, so you can answer that data immediately. You can answer that question immediately. This medicine should or should not be taken.
Yeah, and then you can take the next step. That 200 people, you might find 10 or 20 who would benefit from blood pressure medication a great deal, and the other 180 may not. Right. So, we've been talking about personalized medicine forever. Manufacturers don't really have an incentive to go there because their business model is based on one dose for all, high scale manufacturing. And so providers have moved a little bit in that direction. So we have AI systems now in a provider setting that could predict who is going to progress into hypertension or type 2 diabetes, and post medication who is likely to improve on them. And this is just based on that clinics or that network of clinics data, because we cannot go outside that because of the non-standardization.
Right.
It's a small amount of data, but even with that data, we can show that there is very, very usable information in there. And so going back to the Estonia case, the argument, Peter, always comes back is that, okay, if it's that transparent, if that's accessible, then it could also be utilized negatively by people, right, for other nefarious reasons.
That's correct. Yeah, and so that's where the other case I mentioned would come in. So in Estonia, you really have a secure system. And the reason why the system is so secure is because they're on the border of Russia. They're frequently subject to cyber attacks by Russia. And so their information is biometrically linked, and it's, the most secure system you could possibly imagine. In other countries, you don't necessarily have that level of security. And these systems are lauded. So Taiwan has a very similar system in which you can just go to any doctor you want in Taiwan with your health card and just show up, and the doctor takes your card. They have your whole medical history, and they can address your problem very rapidly and effectively. And they can use predictive analytics. I don't think they use AI, but predictive analytics are probably at least as effective to figure out, who's going to benefit most from which treatments. And another sort of interesting piece of that system is that if the doctor does the wrong thing, if this particular treatment isn't merited in this particular patient, the doctor's pay can get docked. So they have great data. But because they're not really facing the same kind of threats that Estonia faces, one could imagine that a bad actor could come into that system a little bit more easily, because it's not the same sort of high level biometrically linked system.
Right. Yeah, I mean, I wonder, Peter, it's because we have all this different legacy systems and legacy data flow in the US. Is it even possible for us now to standardize it? Sometimes when you start with a blank sheet of paper, when you don't have anything, it's easy to leapfrog, to something that actually works. But in our situation now, we are in such a muddled up, data situation. I wonder if it's even possible to standardize it anymore.
Yeah, well, it's certainly impossible to do it well.
Yeah.
I think a big company like Google, with Google Health 1.0, they really missed a great opportunity, because this was back in 2010. They were trying to decide, should we build an EMR and just hand it out for free, to anybody who wants it, and then we can use these data, for our research purposes and profit. If they had done that, I think we wouldn't be in the situation we're in today. I think the best that we can sort of hope for in America, sadly, in the current system, without universal health care that sort of mandates that every provider use the same system.
Right.
Without, in the absence of that, the best we can hope for is these systems. They have names like RIOs, where they're sort of different systems communicate with each other on the back end and just sort of feed data into a data file that can kind of be used. And with really resourceful researchers and a lot of time, you can do something useful with it. But it's really sad that we don't have it easy.
Yeah. I mean, it seems like the technology is not the issue, right? I mean, EMR systems are basically databases with user interfaces on them. So it's not rocket science. The problem is that the standardization aspect of it has to be really from the healthcare perspective, not from a technology perspective. And so that's where leadership has been lacking, right? It may not be Google per se, but it might be a consortium, some sort of a healthcare consortium that could set out to solve this problem. It's a very solvable problem, I think. And it has, like you say in the paper, a tremendous amount of value for society. I want to jump into another paper, Peter. This was sort of puzzling for me. So spatio-temporal variation of the association between urbanicity and incidence of hypertension among Chinese adults. So essentially, what you think about, generally speaking, when you have an urban society, you tend to have all these problems, including hypertension. That would be your sort of ingoing hypothesis, right? And you find something different.
Right. Yeah. Yeah. This was a bit of a surprising paper at first, and after we thought about it for a while, it started to make more sense. So what we found was that as different regions of China developed at different paces economically, we saw different trajectories of blood pressure. So, like one way you can sort of think about blood pressure in a rapidly industrializing nation is, well, people are starting to eat fast food and getting stressed out and working more long hours and not doing manual labor, and so their blood pressure is going up. But another way you can think about it is some people are getting access to a great deal of economic opportunity that's improving their quality of life in ways that it's not for others. And that second narrative, I think, is probably the right one. So what we found was that cities like Shanghai, Beijing, Hangzhou is where Alibaba is, the big tech company corridors.
Yeah.
Those places were doing pretty well. And if you look at in terms of reducing blood pressure over time, whereas, you would have expected that maybe it would have gotten worse. Relative to the third tier cities and second tier cities, like in Hebei and in Guizhou and other parts of China, those places did pretty badly as economic development progressed. But if you look at the lifestyle of somebody in Shanghai relative to these other places, the kids are getting a really high quality education. They have some of the best schools in the world, and the adults are going to gyms. They're shopping at organic supermarkets, etc. Whereas in these second and third tier cities, there are no organic supermarkets. People don't have the resources for that. They're stressed out and they're driving cars and things like that, but they don't really have access to the sort of first world amenities, you could say, that the people in the first tier cities have.
Oh, that's interesting. So it's almost like there's some kind of a threshold economics beyond which things improve. But when you urbanize something and that urban center hasn't really reached the economics, in terms of services and the general stage of economics for that city, then you see all those problems that we tend to expect in a city.
Yep, I think that's right.
Okay. You have another paper. So this is looking at New York, and you're looking at health effects of expanding the earned income tax credit. So you say anti-poverty policies may hold promise as tools to improve health and reduce mortality rates among low-income Americans. We examined the health effects of New York City Paycheck Plus randomized controlled trial. And the Paycheck Plus test the impact of potential fourfold increase in the earned income tax credit for low-income Americans without dependent children. So this is again, sort of the getting to a minimum level of economics that seem to make a huge impact.
Yeah.
Could you talk a bit about that paper?
Sure. So this kind of goes back to the first discussion that we had, which is, when you provide resources to people that have been deprived of them, that we were talking before about the loss of labor jobs, et cetera, and how the standard of living has declined for a lot of working class Americans. The real question is, can you provide policies that will sort of take place of the benefits that people had under these jobs, like health insurance or income supplementation? And in this case, we're really just talking about income supplementation. So in this randomized controlled trial, what happened was one group received just regular earned income tax credit benefits, which is a federal program that supplements your income if you are earning low wages and you're working at McDonald's, but you're working and you can't make ends meet. At tax time, they give you money back.
Yeah.
And so we asked the question, well, what happens if we quadruple that? And what happens if we say, you can earn more money than under the standard EITC and still get money back? And
so 500 to 2,000.
That's correct. Yeah. So going from about 500 at tax time to about 2,000 at tax time. And we found that men don't really respond to these kinds of incentives in the same way that women do. But they do respond a little bit. And the subsequent effects of that, so we looked at two things in two different papers. One we looked at the mental health impacts, and one we looked at the physical health impacts. In both cases, we found that women tended to respond to these incentives. They got more money back, they worked more, and had better mental health and physical health outcomes in the treatment group than in the control group. So, the net takeaway message is that these programs seem to help and they do seem to work. But we still have some challenges ahead of us in trying to figure out, what's going on with the people that don't take money, that's handed to them.
Yeah, so it's a little bit of a complex incentive, right, Peter? So you have to sort of look forward. The 2,000 is coming to you during tax time, isn't it?
Right.
And so, you have to anticipate and you have to actually do a bit of a calculation to see what the net impact is going to be for you.
Right.
And what you're suggesting is that lazy men maybe not even able to do that. And that is one reason, people sort of favor now the basic minimum income policy, which is, basically saying, let's really say there is a basic income that everybody gets. It's very easy to internalize. It's very easy to plan around. And I think Denmark or some other country in Scandinavia actually implemented it, right, already?
Yes.
And do we have any data as to how that program is working?
Yeah. So there's data from various programs. So Silicon Y Combinator ran an experiment. Finland ran their experiment, and Denmark. In all cases, it seems to improve well-being, but doesn't really seem to have much impact on much measurable impact on other things. Like do they? What one hypothesis was, you have this free time off, you're gonna take this money and start a company and do great things for society. That doesn't seem to be happening.
Yeah, I don't know. I mean, that's probably too high an expectation, right? So the the macro idea here was, if we get into artificial intelligence, robotics, many of the routine jobs humans used to do will disappear.
Right.
So we're going to have a large number of humans who, who don't have the jobs they used to do, and they may have interests in other things, not necessarily, start a company or anything like. They may have interest in, I don't know, art or literature, sort of, improving themselves
Right.
was, I think, the general principle.
Right.
I don't know if we can really expect, the money is going to come back into some sort of societal investment. I wonder.
Right. Right. But I don't think we really have the data yet. But it seems on first blush that we might not be expecting people to be um, writing books and things like that with all their free time either. But it'll be really interesting to see. I mean, I think it's really early. It'll be interesting to see what what happens.
Yeah.
One thing that strikes me about these programs, though, is the the extreme cost of them. If we're talking about in the United States, we're talking about 330 million people. If you give every man, woman, and child some money,
Mhm.
you're talking about a multiplier of 330 million, and very quickly you run into the trillions of dollars.
Right.
So that's not really viable, even from the standpoint of these Silicon Valley firms. If you tax them at 50% or something like that, we wouldn't see that kind of revenue.
Yeah. It's yeah. Like you say, I think we need more data. The one issue is, because we have at least this anticipated discontinuity in artificial intelligence and robotics. Um, you know, Companies may not deploy these technologies because they have employees,
Hmm.
and it's sort of a vicious circle, because these companies will operate inefficiently because they have humans,
Right.
and these are jobs that humans don't really like to do, and they have to do, right? And
Right.
so I think social welfare and efficiency have to be measured, right? I don't know if you have the answers yet, but I think it's much more complex societal question. It's almost like a societal organization question.
That's right. I think that's right, and it's much more easy to sort of pull off in a command and control economy, like you have in China, or even a semi-authoritarian regime like Singapore, which has a democracy but one party system, or Japan. Um, you know, in all of these cases, eh, yeah, you 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 run into issues.
Current issues, and it's going to be culture dependent too. So I don't think there is, something that fits for everybody. And so, if this were a policy choice for different countries, they have to really look at their economy, their culture, and determine what might be optimum.
That's right. I think that's right. And it's sort of interesting to see how COVID has shined a light on this issue, because it really, marriages weren't happening,
Hmm.
things weren't getting processed, businesses weren't getting opened, because all that stuff was done in person and it had to be automated. Um, it could have been that many of these firms, like KPMG, or even university offices, could have been done remotely, 10
Yeah.
years ago.
Right.
And
Right.
now we're doing it. So and what we're finding is that this sort of forced accelerated automation
Yeah.
is producing sort of predictable effects. So some places are falling apart and other places are thriving.
Hmm.
I know I can say in our academic department, things have uh, things have changed a lot, because people are no longer working 9 to 5. They're now working longer hours.
Hmm. Hmm.
which, has good and bad. But in terms of the contracts and payment processing and things like that, the system is completely collapsed. So
Hmm.
we used to be able to pay our research partners in a few days, and now it takes, a month or two.
Hmm. That might be sort of transition difficulties, though, right, Peter? I mean,
Yeah,
these are fixable problems. It's just that we were hit with a shock,
that's
and the
that's
system is
correct.
not set
Yeah,
for it.
yeah. But you also have to think about the precision medicine part of it, which is that there's also an interaction here with personality. Some
Yeah,
people work really well from home, and some people don't.
right.
If you have some people that don't in a system that is completely virtual, you're going to have some big problems.
Yeah, that's interesting. The large companies, their hiring policies are based on set of assumptions how they operate, and then one day you say you're going to operate differently, but they have an employee pool that they hired, promoted, and so on, and their expectations are very different. So it will be interesting. This might be an interesting trial, Peter. You can look at like high tech companies, how they transition,
Hmm.
as opposed to more conventional companies, how they transition, right?
Yeah.
My guess is that high tech companies won't have a big problem transitioning into this process.
Yeah, although you do have to wonder the extent to which people were meeting over ping pong or writing their Google scripts before,
Yeah.
and saying, "Hey, I've got this idea." So, the whole idea behind the cat paper, that artificial intelligence could actually be done. If I remember the story correctly, it was in the Google cafeteria
Mm.
where they came up with Google Brain, and maybe that wouldn't have happened if they were working online.
Yeah. Let's hope we find other ways to interact. I want to talk a bit about your paper, COVID-19, anxiety and distress among the first community quarantined in the US due to COVID-19, psychological implications for the unfolding crisis. You want to talk a bit about that?
Sure. Yeah. So that was a accidental data find.
Yeah.
There's a English company. When COVID first sort of spilled over into Europe, everybody's sort of in panic mode and like, oh, I want to help and contribute. And so at the time, symptom trackers became uh, kind of popular. So this English company made a symptom tracker that basically asked people to self-report their symptoms.
Mm.
So they asked me what kinds of data they should collect, and I suggested that they add a measure of depression to it to see what's
Yeah.
happening to people when they're quarantined. And that provided a really interesting experiment because you could look at the differences between people who had tested positive and the people who had quarantined, without testing positive or who had symptoms. And we found that people who were quarantined with a positive test were much, much, much more likely to have symptoms of depression than
Mm.
those who had a negative test. So
Mm.
you can imagine they were sort of feeling isolated and alone and wondering if they were going to die. And
Right. Yeah, so it will be interesting to look at how things might have changed over time. At the beginning, the uncertainty and the lack of information would have actually compounded this issue, I would imagine.
yeah,
I don't know if things have improved or not, but we at least have more information now.
we do, but one of having been sort of thrust into this world of COVID like every other academic. Uh, one thing that strikes me is how little we still know. I mean,
Mm.
I think that there was a panic, and there was a belief that we're all going to die at first, and then that sort of gave way to well, this is it's old people that are really going to be impacted by this. But I don't think we really know that much about the disease yet. I think, you know, even scientists succumb to the temptation to feel like they have an answer when we really don't. And we're still learning a lot about this disease. You know, there's at least some evidence now that young people are experiencing permanent myocardial damage
Right.
and other organ damage and chronic symptomatology, even if they're asymptomatic. So, you know, this could be destroying a generation, or it might not. You know, we just don't know.
Yeah, I mean, it is the disease burden. We don't have any data to really compute the disease burden for COVID,
Isn't
right?
that
So,
amazing? Isn't that amazing? I mean,
yeah.
it's already September, I think.
No, I mean also the long term, you know, like you said, the long term effects, right? So
Yeah.
the 1918 19 Spanish flu, it appears that, you know, 1 million people who actually recovered from that Spanish flu had Parkinson's disease 10 years later.
Mhm.
So, yeah, we can determine or speculate on sort of the tactical effects of COVID. Some of it we can see, but we have no clue, right?
That's right.
You know what the long-term effects are going to be. But I was told, Peter, that the vaccine is going to arrive on November 2nd, which is,
Yes.
you know, which is encouraging.
Yeah, that is encouraging.
So I want to close with a different topic. Not necessarily different, but so health and economic consequences of applying the United States PM 2.5 automobile emission standards to other nations,
Uh-huh.
a case study of France and Italy.
Uh-huh.
And so you say the US was, you know, among the world's strictest automobile emission standards. It's now loosening them. It is unclear where a nation should draw the line between the associated cost burden imposed by regulations and the broader societal benefits associated with having cleaner air.
Mm-hmm. Mm-hmm.
You want to talk a bit about what you found and, you know, what the implications might be?
Yeah, and this is not a politically driven study. You know, this is a question that is you know, I think really of critical policy significance. It's not a question of you know, oh, we just need to put catalytic converters on every car and you know, implement as many safety features as we possibly can and put speed cameras everywhere. You know, there's a real cost to all of these things that we do, and the question is, you know, where do we draw the line at any point in time, and how do we move that line over time?
Yeah.
And in this case, you know, in the United States, you know, in the 1990s, Los Angeles had pink orangish colored air because there were so many emissions from automobiles, and you could see that all the way up the coast to Santa Barbara.
They got it back last week from the fire.
Yeah. Right. This is a lot of unintended consequences, right?
Yeah.
This made it easier. Maybe these regulations, at the end of the day, made cars more viable and increased global warming. Yeah, this is exactly the thing. So yeah, so what we found in that particular study was that countries that hadn't taken such an aggressive stance towards pollution control measures on their automobiles paid a price for it, and they paid not just a price in terms of you know, lung disease and heart disease, premature mortality, but they also paid a price economically for that, because especially in these countries with you know, nationalized healthcare systems, you know, it's basically the regulatory costs could have been paid for by the government almost, and just given, they could have just given the money to the automobile industry, and they may have recuperated a lot of it in their health system.
Wow. Yeah. And so the metric here is quality adjusted life years, right?
Yeah.
And I mean, the numbers may not make intuitive sense, but essentially what you're saying here is that those stricter standards obviously result in higher quality air and environment, and that reduces diseases and increases essentially the quality of life and the total quality adjusted life years of all people.
Correct. That's right. And these studies were done in the most restrictive and conservative ways possible. So we didn't really look at spillover effects too much into factors like economic productivity when somebody's, partially debilitated by chronic lung disease, for example.
Right, right. Yeah, and the other spillover effects here, which is a bit difficult to measure, but I
Yeah.
think it's significant, is the innovation aspect. So suppose I take a system and I say you have to go from
Yeah.
0 to 10 to 0 in a matter of 6 months. People will figure that out how to do it,
It's
and
amazing.
along with it will come a ton of innovation, right?
Yeah, that's
And
right.
so, yeah, I wonder, all these policy choices that we look at, we sort of measure, kind of the immediate tactical cost and benefit and say, well, it's too expensive. Um, Maybe there is some way to, sort of look at in a more standardized way what policy choices actually bring. Many of the choices, as you say, result in some sort of a health angle.
Yeah.
And once it does that, all the numbers are out of the window because we are spending $4 trillion in
Right.
healthcare today. Right?
That's correct. That's correct. Yeah. I mean, I think that is, especially in the United States, the math ends up pretty easy in these in these studies because you don't have to add all of these unintended consequences and nuances because you get your answer without adding those. In other words, even when you don't look at, for example, catalytic converters, as you're saying, drive innovation. If you're telling people, if you're telling automobile companies they have to reduce emissions, what you're going to do is you're going to encourage people to go into material sciences, and the material scientists are going to do other things like invent new silicon alternatives, et cetera, et cetera, et cetera. So you have all these spillover effects, but you don't really have to worry about it in the US because our healthcare costs are so big. You can just look at healthcare costs in these analyses, and that's you're done.
Yeah. And the other question in this policy choices also would be sort of the timing, right? So sometimes I'm just speculating here. Suppose I have a policy that says you have to reduce emissions to zero. In other words, you cannot have a gas-driven automobile anymore. A very harsh policy choice. It's going to have a tremendous benefit because right now, when you have electric cars mixed with gas-powered cars, you can only get to certain efficiency, right? You cannot get to full autonomous, and so you have to sort of pull back on innovation because you have legacy drag, so to speak,
Correct.
on the road, right? So sometimes, a big policy change might be a much better way to tackle something like that.
Yeah, and I think that's one of the reasons why we're really seeing nations like China leapfrog other nations is because, they have the ability to sort of say, okay, well, we're going to standardize what a charging station looks like and put charging stations everywhere, and incentivize the development of electric vehicles. And if you go to if you spend any time in a major Chinese city, it's really remarkable because if you stand on a street corner of five lanes on either side, third ring road, they're silent because all the cars that are moving around are electric. And as you say, just having those electric cars on the road is going to be driving innovation because all of those manufacturers are competing for who can make the most efficient battery, who can make the most autonomous systems. etc. And that's one of the big reasons why Tesla moved really quickly into that market.
Right, right. Yeah, so a lot of challenges in front of us that makes your research always interesting.
Thank you.
Yeah, this has been great, Peter.
Yeah, it
Yeah,
was a
thanks
really
so
great
much.
conversation. Thank you.
Yeah, thanks so much for spending time with me, and yeah, good luck with all your research.
Okay, thank you
Thank
so
you.
much. Take care.
You too. Bye.
Bye.